Dr. Abd Elaziz is eminent professor of neuroradiology in Alexandria University.
بسم الله الرحمن الرحيم. تحياتي لحضراتكم جميعا وشكرا جزيلا للجنة المنظمة على الدعوة الكريمة دي. Today I will present our experience using the 3 Tesla MRI in the clinical application of arterial spin labeling. First, I would like to thank my professors and my colleagues in Alexandria University, Banha University, and Port Said University. During the coming minutes, we will go through the basic principles of arterial spin labeling, our experience in the clinical application of ASL, and importantly, the pitfalls and artifacts. Arterial spin labeling is a technique that uses magnetically labeled arterial blood water protons as endogenous tracers. So we don't have, it is an non-ionizing, non-invasive, suitable for all patients, especially pediatric, renal insufficiency, and in repeated follow-up. It provides only a blood flow map, which is beneficial in many conditions. The arterial blood water is labeled by RF pulse that inverts or saturates the longitudinal component of the MRI signal of the protons in the flowing blood at the level of the upper neck, carotid, and vertebral arteries. This will travel through the carotid and vertebral arteries to the brain. After a delay time between the labeling and imaging acquisition, which is called the post-labeling delay, the labeled dispense reaches the capillaries and passes into the brain tissues. The paramagnetic tracer exchanges with the tissue water and alters total tissue magnetization, reducing it and consequently altering the MRI signal. During this time, an image is taken, which is called the tag image. We repeat tagging and stop tagging, which is called the control image, several times like this, providing 2 images, which is the ASL labeled and the controlled. And if these are subtracted, we will get an ASL perfusion map. It can be presented as a perfusion map like this or color-coded map like the one on the left side. This is a dynamic susceptibility contrast cerebral flow map, and this is the ASL map. They are almost equivalent. Regarding the clinical applications of ASL in neuroimaging, we will divide them into hypoperfusion and hyperperfusion groups. Focal hypoperfusion. Look for this case. We have a recent effort involving the left middle cerebral artery territory, presented as diffusion weighted restriction. And if you compare the area of the restricted diffusion with the ASL hypoperfusion, we will find there is diffusion-perfusion mismatch, meaning that we have an ischemic penumbra. Another case, right middle cerebral artery occlusion, basal ganglia acute infarction, and the arterial spin label map shows larger perfusion defect, meaning that we have an ischemic penumbra. On the other hand, there is a large infarction involving the temporoparieto-occipital region on the left side, and the ASL map shows equal size of hypoperfusion, meaning that we don't have penumbra. In patients who presented with a chronic cerebrovascular occlusion, the diffusion and the flare image may just appear totally normal with foci of ischemic changes without restricted diffusion, but on doing ASL sequence, we can find areas of hypoperfusion like this, which is seen in the right parietal region. But take care. This first one is ASL taken at 1.5 delay time, and this is another delay at 2.5 seconds. We will find that there are some areas of adequate perfusion seen within the areas of the marked hypoperfusion. This delay is important, and it warrants us to do multi-delay ASL. Why? As you see in this case, this is a delay, post-labeling delay, 1.5 seconds. We will find there is an area of hypoperfusion at the left parietal lobe. But on doing it after 2.5 seconds, there is collateral serpiginous high signal in the ASL group. If we subtract the first row from the second row, we can get the area or the load of the collaterals, which is very important for the clinician to manage such patients by endovascular intervention. This is an area of encephalomalacia with corresponding hypoperfusion on ASL. And as you know, in the interictal phases, the area of epileptic focus is usually hypoperfused, while in the immediate post-ictal, it may be hyperperfused. And this is a case of normally appearing morphological features of the brain in the left frontal region, but the ASL shows hypoperfusion, which points to the area of epileptogenic focus. In low-grade glioma, as you know, usually it is hypoperfused. The solid enhancing component is hypoperfused. In cerebral abscess, in spite of the enhancement of the wall, there is marked hypoperfusion. This is a case of Sturge-Weber syndrome. As you see, the area of atrophy in the right parietal lobe shows hypoperfusion, but take care, this may, the drop of signal here may be due to calcification, which is associated with Sturge-Weber syndrome. In PRESS, we have two phases. In the first phase, there is vasoconstriction. You know that there is autoregulatory control loss in PRESS. In the first phase, there is vasoconstriction associated with hypoperfusion. Later on, hyperperfusion due to vasodilatation occur. So PRESS can be presented by hypoperfusion or hyperperfusion according to the stage. This is a case of our group showing the hypoperfusion stage in PRESS. Regarding global hypoperfusion, it can be seen in elderly with brain atrophic changes. Regarding hyperperfusion, focal hyperperfusion, this is a case of meningioma, as you see, live bulb. This is a case of multicentric GBM, also showing hyperperfusion. This is a high-grade glioma showing no enhancement involving the left middle cerebellar peduncle. The MRS curve is malignant, and the DSC perfusion shows hyperperfusion. And this is the ASL equivalent map showing the red color of hyperperfusion of the lesion. Another case of ependymoma also showing hyperperfusion in ASL, metastases. And sometimes when there are hemorrhagic metastases sparing some areas which shows enhancement, we can see hyperperfusion in this area, okay? This is another case of hemorrhagic metastasis, and there is only a small focus of hyper enhancement, not masked by the blood product, and it is markedly hyperperfused on ASL. And this is from the literature, subepidermal metastasis, also showing a hyperperfusion. Developmental venous anomaly, it can show itself hyperperfusion or hyperperfusion of the surrounding parenchyma. This is an example of the hyperperfusion of the DVA itself. And this is the example of hyperperfusion of the DVA and the surrounding parenchyma, maybe due to disturbed autoregulatory effect or the venous congestion in this area. Also, in aneurysms, there is trapping of the protons. It can show that like this hyperperfusion within the, or trapped spans within the aneurysm, and it can show also the defect caused by, or the defect in the perfusion, because this is a posterior communicating aneurysm, so the left occipital lobe is hypoperfused. AVM also showing hyperperfusion and steal phenomena in the rest of the right cerebral hemisphere. In cerebral hematoma, we can see hyperperfusion surrounding the hematoma due to hyperemia. And as you see, there is a tiny peripheral aneurysm trapping the protons and showing enhancement. Another case of cerebral hematoma, and don't mistake this for a hematoma on top of aneuplastic lesion. In luxury perfusion, also we can see hyperperfusion in encephalitis. Global hyperperfusion is usually seen in cases of hypercapnia due to chest disease like this patient. It is important to be familiar with the pitfalls and artifacts of arterial spring labeling. Age-related dependent variability, as you see, cerebral blood flow is of low level in the perinatal period, increases to a peak at 3 to 8 years, and then gradually decreases to the adult level. So this is normal. Also, we can see physiological frontal and occipital hyperperfusion. If the patient is opening his eye or thinking during the examination, we can see activity in these areas. These are normal. If we have any susceptibility artifact due to hemorrhage like this, there will be no signal in this area. Of course, if we have susceptibility artifact due to metallic structure in the paranasal sinus like this, you can see this appearance, which is not due to actual hypoperfusion. There is loss of signal. This is a good example for metallic artifact due to the metal in the valve of the endotracheal tube beside the left carotid artery. After it was corrected, the perfusion is okay. Also take care that tortuosity of the carotid artery in the neck may cause delay of arrival of the protons on the same side. So it is important to use multi-delay ASL technique if it is available. Of course, motion artifact can give this appearance. Another thing is labeling of the CSF at the level of the neck. And as you see, it can give hyperperfusion, false hyperperfusion surrounding the brainstem, and to correct this, put the labeling level just a few centimeters lower down. Another thing, don't do ASL after gadolinium. This is a case of ASL after gadolinium, and repeated after clearance of the gadolinium, because gadolinium decreases the T1 relaxation time, resulting in loss of signal, rapid loss of signal, and failure of ASL. Sometimes the ASL is trapped in a giant aneurysm, like in this case, and it can give, due to pulsation effect, what is called streaming artifact, like in this image, in the coronal image. And of course, you should repeat with a more delay to see the perfusion upwards. Also, there is a phenomenon called arterial transient artifact. Sometimes the blood is slower than the delayed time, and you make the imaging while the protons are in the arterial system. As you see, this image, there is the hyperintensity is along the circle of Willis and the arteries, and if it is repeated later on, there is adequate perfusion of the brain. The similar is seen if you have collaterals like this. You can see serpiginous high signal, and you should repeat at a delayed BDL. Another artifact, which is called the border zone artifact, which is natural due to fading of the signal. You can see it at the border zones. This is not actual perfusion defect, because if you repeat it with a more delayed time, you can see adequate perfusion. This is a very nice example of ASL signal to be seen in the sagittal sinuses or the transverse sinuses. And this means that we have direct arteriovenous fistula, and they say that this may be the early sign to detect dural arteriovenous fistula. Another example of this venous signal, if we have a carotocavernous fistula, there is trapping and steal of the signal into the cavernous sinus. Another thing is the venous ASL signal. If we have stenosis of the internal jugular artery with reversal of flow of the blood in the sigmoid, so it will act as if it is arterial, and it will be labeled during the labeling. So we have some limitations of ASL. It is a relatively low signal to noise ratio, which is a problem that can be amplified in clinical population because of the patient lack of operation, vascular disease, and artifact. Clinical ASL is a semi-quantitative tool. Heart rate, cardiac output variations, and anemia may affect the image quality. Finally, to take-home messages, recent technical and post-processing advances making ASL available for routine clinical practice. Several investigations demonstrated that ASL perfusion is a promising non-invasive technique that may be comparable with the other invasive methods. Adding the ASL sequence in 4 to 5 minutes to the routine brain MRI may help better lesion characterization without additional cost or undesired side effect of contrast. These are my references, and thank you for your attention.
Thank you very much, Professor Dr. Abd Elaziz, for this elaborate talk. And I'm sure many of you will have questions, but we'll postpone them to the end of the session. And